All right. Hello and welcome to another Down Fracture podcast, a podcast for talking jaws. Downfracturepodcast at gmail.com. We got a couple emails this week. They were good on the TMJ replacement kind of troubleshooting. What'd you think of those?
Yeah, I liked it. I mean, I like someone mentioned a trick I hadn't thought of, or at least I hadn't used. Or I hadn't used and I hadn't thought of, I guess, which is securing the condylar segment and then placing the fossa segment from the condylar position, right? Like you secure the condyle before the fossa. Seems wild to me.
Yeah,
Uh,
I mean, actually, I think what they mentioned was like they didn't really secure it, and that was
like with just single screw, is that what you mean?
I mean, I think they just kind of like put it in there, held it. I'm
For,
not
for
entirely
the
sure, but
fossa, right?
yeah, put the faucet in or put the condylar component on, use that to help guide the faucet component. But what they mentioned was that they weren't they weren't sure if the faucet component was actually stable or if it was just being shoved up by the condylar component, and so it seemed stable.
Yeah,
And so it's
the
still a nice
idea,
little trick or tool to try
yeah,
in some instances.
the idea wasn't like as a routine thing, but just when your fossa is maybe not fitting as well as
Right.
you'd like it
It's like a
to.
syndromic and ankylosis case where like one of the guides for resection wasn't fitting and then the component didn't fit well. So kind of the things that we were talking about of trying to make a custom prosthetic fit when it's or trying to troubleshoot its fit when it's not fitting perfectly kind of thing.
Yep.
Thought it was an interesting way to do it.
Yeah, I thought
You
that
could
was interesting
always
as well.
you could always put a screw or two in or put it most of the way down to kind of help or like you were saying and then reevaluate be a way to go. Well, yeah, so we got some feedback. That's always nice. Keep it coming. We will learn from you too. So we like hearing these things. Mariners, Sam, are not looking so hot.
I mean, we're up and down. We got to get the down out of our system to look up. We've never been in a game seven. Can you believe that? The
I can
Mariners,
because we're never in the playoffs.
as an organization, have never played a game seven. So, thus, we've made it farther in the season than ever. So it's already a win, right? So from that standpoint, Mariners are winners. I think we can pull it off. Canadians are pretty tough though, so we'll see what happens.
Man, second place is first loser. There's no moral victories here.
Yeah, but I mean, I still think we can pull it off. So we
Oh, you are more hopeful than I am. You remember the last outing that we had with old Kirby, right?
wasn't the best, but I remember good outings with Kirby. He tends to have like a no-hitter going and then he gives up like 5 runs. So we just got
Yeah.
to take him out as soon as someone gets a second hit off of him. And I bet that's how they'll use him today. But
I bet we go through seven pitchers. What do you think about that? What's the over-under on pitchers utilized by the Mariners tonight?
7 seems high, but not unreasonable.
We'll
Yeah.
see. Wu will pitch.
Yep.
See Kirby and Wu for sure. Probably get some Brash in
Yep.
there. Seven may be
Lizardo.
high,
Yep.
but five,
Yeah.
maybe five.
I can see Castillo pitching. It's going to be a lot of people. So I think they're going to have a short leash with Kirby. So
Especially
that's all
since we
right.
have to what Friday to rest after this one. So
Yeah.
leave it all out there. Don't pitch to Vlad.
No,
Oh,
just
all
walk.
right.
All
We
right. Too
got off
much
topic.
baseball. We're supposed to talk about Jaws, right?
What's the difference?
Well, I mean, we have a few other, let's see, we have some guests next week and the week after. Did we talk about ACOMs, by the way? Have we mentioned that?
I don't think we've mentioned that. Are we allowed to mention that? Like,
I feel like we should be, right? Isn't it on the thing? We're doing a live broadcast of Talking Jaws from ACOMS, the winter meeting. So that is a great meeting, by the way. So anyone who's listening to this who hasn't been to the winter meeting for the American College of Oral Maxillofacial Surgeons, that used to be known as FACES. FACES was just a surgical orthognathic conference. They used to have orthodontists and jaw surgeons in equal measure. Um, and started by Myron Tucker and Paul Thomas, I think, who's an orthodontist, or a surgeon and an orthodontist, that I'm sure most people have learned from. And if they haven't, they didn't know they learned from them, they learned from them. This topic a little bit, I guess I was turned on to it from Myron. Myron gave me a lecture when I was a fellow and kind of got me interested in this. So our topic of our podcast today, I guess, is inspired by Myron. But to finish the thought, the American College of Oral Maxillofacial Surgery meeting, the winter meeting, is a ski meeting, and you just talk about jaws with other people. So you just hop on the lifts and um, learn more outside of the classroom than inside the classroom. Have you ever been over there, Wasson?
I don't think I've ever been to this meeting. I think I've been to some ACOMS meetings before, but not the winter meeting. So
Yeah, the winter meeting, they merged with Faces. I don't even know, like maybe 5 or 8 years ago, 10 years ago. But yeah, it's a long history of talking Jaws, and we're gonna formally talk Jaws at the meeting. So that's gonna be exciting.
we do formal? Like
No, yeah, no, it's but
I was
it'll
gonna
it'll be a
say,
more formal situation because it
I guess so.
anyway.
Um,
That's in February this year, so hopefully some people make it out there. It's a good meeting.
yeah, yeah. Um,
Um, Go
what are we
ahead.
gonna talk about today?
I think our discussion was premolar extraction, surgical premolar extraction during jaw
Yeah,
surgery.
yeah. I think this is gonna be your baby. You said Myron gave you kind of talked to you about this, went over this stuff with you in fellowship.
Yep. Yeah. I mean, I feel like it's hard to remember when you learn things. I definitely remember hearing those lectures from Myron though when I was a fellow, um, of taking premolars out at the time of surgery in the maxilla or mandible. Um, and I guess I've practiced in that world. I guess I just assumed other people did, and I was planning a case just prior to this meeting, where it came up, and I kind of got the feedback that I'm a bit unusual for planning it. When does it pop into your mind for premolar extraction at the same time as lower jaw or upper and lower jaw?
Yeah, we were talking about this before we came on a little bit, and as I was telling you then, um, I think the the bonus of this or the good of this talk is going to be I don't really do that, which is probably going to be similar to the majority of our audience. And so that thought rarely comes into my mind that at the time of surgery, I'm going to take out premolars. And by just to clear this up for the listeners, we're talking about during orthognathic surgery, at that surgical visit, removing premolars as part of the plan, either to close, I mean, well, I guess we'll go into indications, but my experience doing that is either minimal or none. As I look back and as I get further along in my career and look back, I kind of look at the way that I was trained and the surgeons that I was trained by, and it seems just very much in a plan of surgical efficiency, possibly at the expense of overall treatment efficiency, meaning very much in the let's do everything orthodontically ahead of time so that the surgery goes as quick, smooth, predictable as possible. Maybe at the expense of some of these things of, well, hey, could we shorten treatment time by X amount of months or a year plus by doing some of these things at the same time? So it's not something that I readily bring up to patients. It's not something that I readily think about in my plan. And if I'm thinking about removing premolars, it's usually ahead of time. And that is different than what you do sometimes. So walk us through what you do and when you think about even bringing that to the patient as part of the plan.
Yeah, I think it's a good tool to have in your toolbox. It's not a routine practice by any means. But I think for the certain case, it's really useful. I think for traditional premolar extraction. So I think we all learned about premolar extractions to set up cases correctly for resolution of crowding, for incisor angulation, um, that sort of thing, right? And, maximize the advancement in theory in the mandible, maybe optimize aesthetics, that sort of game plan from the beginning. A lot of times people don't like premolars being extracted. I think nowadays I hear that more frequently than, oh, yeah, that sounds great. Let's take some premolars out, both on the patient side and the provider side, by the way. I feel like both of those camps don't love my game plans of premolar extraction as a setup. And it's, I think, for kind of similar reasons. Like if there's not anything wrong with the premolar, then why don't you just leave it alone? From ortho, it can kind of be a long setup to take the premolars out and then close all the gaps. And if you're still going to do surgery, um, what about surgically closing the gaps, right? So I think there are times where surgery makes a bit more sense. Surgery first cases, whether that's breathing issue, whether it's aesthetic, insurance issue, that sort of thing. Sometimes you get picked up on a case that you didn't originally plan. You know what I mean? Like someone moves into town, maybe the orthodontist retires. You kind of get involved in the mix, and to you, maybe some premolar extractions make some sense. So I think when it comes to this sort of thing, in my world, premolar extraction is used infrequently, but when it is, it seems to be super useful. So want to just talk about mandible? Take out mandible premolars. I've a recently planned case for that one. Our audio people aren't going to be able to appreciate it, but I can't share your.
Oh yeah, I have this awesome screen up, so you can't even share.
You
There you
do
go.
have an
Try
awesome
now.
screen. So generally premolar removal in the setting of the mandible or the maxilla, but largely in the mandible, has to do with the thought of, am I really going to do a chin to make up this hold away ratio? So if you're doing jaw surgery for upper and lower jaw surgery, um, so in this overall plan, the mandible's relatively small in relation to the maxilla, right? So the occlusal plane's a bit flat in this scenario. Premolar extraction ahead of time could be done, but premolar extraction at the time of surgery can be done as well. And they basically have a similar effect in this situation, which is there's an excessive A and B, but class one-ish molars, right? So in this situation, taking out premolars is the same as doing a subapical. So subapical is incision, it's just chin incision from a patient's perspective. But an anterior subapical is canine to canine most commonly, and you take out the premolars. Technically, this slows the case down dramatically, by the way. So if you were hoping to get this surgery done quickly, I don't think I would have that focus. Let me see if I can remove those. This is my problem. I have a hard time talking and clicking the computer buttons. And so the idea is bringing the posterior segment forward while you're keeping the anterior segment. And that way the skeleton is more in balance and you get a bigger airway response with mandible advancement. Premolar extraction. So obviously you take the tooth out from above. The technique of doing this, by the way, is tricky. My advice on these sort of things is pay attention to the loop of the nerve on the mental foramen. Look out for canine apex dilaceration because canine apex influences how you plan, and never entirely close the place in the space in your plan. So if you plan on taking out a premolar, don't make it to where the teeth touch, because not only is there excess gingiva, it's just technically hard to remove as much bone as you think you need to remove. Does that make sense?
It does. I mean, that was going to be one of my questions is like on the technical aspect of this, I think all of us could be very well equipped to extract a premolar, but even your order of operations here, like what do you, I assume the extraction is like the first thing you do.
So no. So I tend to treat this like segmental mandible surgery, which is you start with the chin to open it up and dissect, do the right sag, left sag, and then put them in the intermediate splint. Take the teeth out at that stage, and then the subapical. I flirted with taking the teeth out as at the beginning, like to start with the teeth extraction because the mandible is stable. But generally, premolars aren't that difficult to remove, and it felt timing a little bit better for that. I mean, the mandible, the concern would be is tearing the gingiva, but luckily that doesn't happen too frequently. You have you ever seen that with the premolar extraction in
Not
the
really.
mandible?
I
Yeah.
mean, maybe, but not a lot that I can recall. So wait, let me make sure I understand. So you're putting him in intermediate splint, fixating the sagittal osteotomies before you do this? Is that what you're saying?
No, no, no. Open the chin, dissect, do right sag, left sag, put them in intermediate or roughly in intermediate after I take out the premolar. So I guess take out premolars, put them in intermediate, and then push the anterior segment back or as close back to as you can. Plate the anterior subapical and then plate the sages at the end.
Okay. So I'm assuming you have to remove some bone from the extraction site?
Yeah, so in mandible, the removal of the teeth, you can remove them surgically or you can just cut and then remove the whole segment. And I've done that both ways. I think there's kind of pros and cons of those, just depends on where the roots are. But you go oscillating saw or piezo to cut around the tooth, right? So
Hmm.
you can cut the subapical all the way back to the premolar and then remove the tooth and the bone with it, right?
Okay.
The difficulty is the angulation of the saw from the axis of the lip. The saw tends to taper in, and so when you move this thing back, these things tend to bump into each other. Does that make sense? Like it's never quite parallel. It's always like tipped in with your saw. And you want to maintain blood supply to this anterior aspect. When you're doing a subapical, blood supply comes from the lingual aspect, right? So you want to maintain the lingual mucosa, which is kind of an important aspect of this.
Hmm.
But the game plan to not entirely close the space is one that I've kind of learned over time. In the mandible, by the way, this shows how sometimes the premolars can be wide. So in this, when you move the anterior segment back, there's a transverse arch discrepancy that shows up. And on occasion, you have to do a midline in the chin. That's probably overcomplicating it, but that's certainly an approach when it comes to this. And then stabilizing these things with wire bonded, just like you're doing segmental surgery in the mandible or the maxilla, right? So generally speaking, blood supply is the tricky part, and then just how long the surgery is the hard part of this sort of thing. But for people who are either congenitally missing premolars and they have a space that's left open by their orthodontist, um, you can save them dental implants. That's actually a pretty good reason to close the spaces. People who should have premolars ahead of time, but they, for whatever reason, don't, that treatment plan isn't a good idea. And then sometimes just like for asymmetry cases or that sort of thing, I think in the back of your mind, entertaining the idea of a premolar to help out the overall treatment plan can be helpful.
Hmm.
What do you think?
I
You
mean,
interested
when
or
I hear
not
you
really?
when I hear you talk about it and I see it, it's like, okay, that makes sense. Yeah, this is one of those where I feel like it's the level of complexity there. It's almost like I don't know that I would incorporate that a lot into my practice. Now, let me ask you this:
Yeah.
Do you do you have enough volume of doing those things to have an idea of like complication rates, or like, I mean, is this fairly straightforward since I haven't done any, maybe potentially of this, or if I have, I don't even remember it. Like, where are you getting into problems with this, or is it fairly straightforward?
Because I was trying to estimate what my lifetime experience with this sort of thing is, and it's hard to know, right? I feel like these days maybe a couple cases a year is the right volume, maybe two or three. So maybe 30, 40 cases, something like that. Um, the thing that always stresses me out is blood supply in
Yeah.
general when it comes to surgery, segmental surgery, mandible, segmental surgery, maxilla. I want to do everything I can to maintain blood supply because that's probably about the worst thing that can happen, right? You're taking out a couple of teeth, particularly in the standpoint of you're taking out a few teeth and you end up losing other teeth. I luckily
Yeah,
haven't seen the
exactly.
losing of teeth yet in my practice, but that's out there as a possibility. And so disturbing the blood supply is a real concern. Um, so luckily I haven't seen it, but I would be concerned about that in general. I think from your I don't know, like first 10 cases in practice, maybe taking out premolars is a bad idea. But I think it's a good treatment plan in the right situation. So
Are there
maxilla, I
any,
don't feel like I'm convincing you at all. Like not even
well, I
a little
mean,
bit.
this is one of those things where convincing me, in my mind, I'm trying to just picture when I would actually do this, and instead of preemptively removing them and putting them through ortho, like I don't know, man. I don't know that I'd do it.
What about this? All right, here's a lady. She had upper premolars taken out and they maintained her lower premolar space.
Was that intentional and planned for implants?
It planned for implants. Yep.
Okay.
Congenitally missing upper premolars. Ortho sets her up. Class 3, and now you have to do jaw surgery on her. You you're maintaining those spaces and doing a genio?
I mean, that's probably what I would do.
Really?
I mean, so we're having this talk and this topic, and I guess I can't
Sorry,
remember what.
I'll describe the picture just because
Yeah,
so this is skeletal class 3 lady with it's like one of those class 3 people who's also retrogenic and she has spaces for her second premolars. They look like they were the spaces were maintained ready for dental implants after treatment. Comes in with a reverse overjet, maybe like -8 or 9. And spaces for the second premolars to be restored, and then no spaces in the maxilla. Um, you know what I'm going to treatment plan on this one, which is removal of the spaces. And then that allows the chin aesthetics to be a little bit better. You would send them back to ortho to close the gaps.
aesthetically, I wouldn't. I don't know that I'd like that, but I mean, she does. I mean, she looks like she could tolerate the maxillary advancement, though. Like, I
Yeah.
mean, I know you're still going to do that, but I mean, like, I wouldn't look at that and say, "Oh, I'm hesitant to advance her maxilla to the current mandibular incisor position." But if you close those spaces, that's going to change. But I mean, why not? Why not implants?
Well, sure.
Like,
You could do implants. You do a double jaw chin and then do implants, but we could also just take the spaces out and it saves her 2 implants, right?
yeah,
I mean, from a standpoint, you could, obviously there's not a wrong answer in between those, but the idea of taking out the premolars to allow for better chin aesthetics while also getting the teeth to match up and finish up ortho without the need for uh, two dental implants is pretty nice. So second premolar
well,
is a little bit harder to manage just because of the nerve and everything.
go back to
Um,
that. Can you go back to the post-op stuff?
yeah,
I mean, chin aesthetics are good. I
I
mean,
thought you were going to say the maxillary wisdom tooth still there.
it is still there.
I know it's offensive.
I mean, I guess you don't care about your patients.
Yeah.
Um, yeah, I mean, it's hard to nitpick it too much, like when you see the outcome and say, okay, that's a good outcome, because you don't get to have it both ways as always and say, well, what would it look like alternatively?
But I mean, the alveolar bone in the anterior mandible in class 3 situations can be hairy, right? Like I think that could stress people out in terms of orthodontists bringing the teeth back. So if you plan to take out premolars and then distalize all those teeth and you get a cone beam and it looks like there's no bone around those, maybe they think, well, why can't you just manage it surgically? And I think we can, right? I mean, you can. The concern is, just performing the operation. So
I mean, I can't honestly recall. Again, it may have happened. I just can't even recall an orthodontist even running that scenario by me either. Like, hey, can you close these spaces once we take teeth out? Like, I don't ever recall that discussion. Like, do you have orthodontists bring that up to you, or is it always your idea?
Um, I wouldn't say it's always my idea. No, I mean like floating the idea of can you just take these teeth out at the time of surgery? That's come up. Yeah, on discussion. Because I mean, like the first thing that I was showing you, which is someone who really doesn't have much orthodontic needs. They don't have much crowding, teeth match up reasonably well. Maybe they're doing it more for aesthetic reasons. I'm not entirely sure. What that allows for is for better width in the mandible, right? So like lower premolar extraction allows for a wider arch form, jawline to broaden out a bit, um,
With subsequent advancement.
with advancement. Yeah.
Yeah. Yeah.
Which you can do that ahead of time with premolar extractions, or you can just do it at the time of surgery. So, I mean, efficiency, there's reasonable case for it. I mean, if it takes you another 45 minutes in surgery, as long as you can do it safely, um, I don't see why it wouldn't be part of the repertoire.
Yeah, that's interesting. I mean, I've had orthodontists ask me about taking teeth out during surgery or even doing implants and stuff like, that part I come in, I get from time to time, but not like taking the teeth out and closing the space, I guess is maybe what I should say. Like that, I don't recall ever being asked. I mean, I've been asked, can I create space? And that's
Yeah.
where it's like, no, slight, but
Can't
not
create much space with
right.
jaw surgery, unfortunately.
Yeah. And
Um,
so that I
what's
that
your
I
upper
come up
limit on
with.
that, by the way?
What's
Two,
what?
one, upper limit on space creation with
And
technical surgery.
I try to do as little as possible. Like, I mean, that's one thing I do not really play around with is I don't really want to create much space. Like, it's one of those things where the risk of trying to create space is like what can happen can be catastrophic. And then I think the benefit of what you get from doing it, which is like you're saying, maybe you get a millimeter, like the risk reward balance there seems so minimal.
Well, because I think the gingiva is less tolerant of stretching than it is some compression, right?
Of
Like taking
course.
out
And
premolars in the maxilla, commonly premolar extractions is the posterior segment, like the palate isn't changing. You're just taking the segment out of the posterior segment in a three piece. So that I guess proximal segment is moving forward. And so you have some bunching up of the gingiva, but it isn't, it doesn't seem like it's impinging upon the blood supply, right? Whereas if you're trying to open up extra space, because they're congenitally missing some laterals and they have 3 millimeters, and you're trying to get it to 6 millimeters, I just have never been able to find success with that. Like never. Um, I don't know. I think the times I've taken that on, every time I build on the plan, because I can only get like 2 millimeters at most. Honestly, I think it's on the amount of space creation. I don't feel comfortable more than 1.5 millimeters. So
yeah, so I mean, in that scenario, if there's a tooth missing and we're making an osteotomy through an edentulous segment and trying to get some width, I'm more on board with that. But when you're talking about trying to create space between two adjacent teeth, then definitely no more than a millimeter. And even a millimeter makes me nervous.
yeah. So what I'm getting at in terms of the blood supply thing, I think compression seems to be more safe than the stretchiness of things. So closing premolar, let's say you plan to close at 5 millimeters. Um, it's more just like bony interference is the problem, and then stabilizing the segments is the problem. Um, as long as you're good about controlling the saw and the paddle aspect or the lingual aspect, I think you're in good shape.
Hmm. So that's how you do it. You almost make sequential cuts or take a wedge out with the oscillating saw. Or are you taking like a bone file? Can you even fit that in there? Or like what are
I
you
mean, you
doing?
can do a little bit of that. It just starts feeling a little crazy. I think just plan so you have spaces. Because if you have to take out a lot, it's like narrowing a mandible. Um, the bony segments interfere to such an extent that um, even if the teeth narrow, the bone tends to widen anyway, just from the lingual interferences. And so you can go in with a Fisher burr, you can plan to do like diagonal oscillating saw cuts, but I don't know. I think um, the bony interference is more of a planning issue. So if you plan for it to be perfect, they still need braces. You still need to do ortho, but ortho closing like a millimeter, 2 millimeters is easier than closing, the whole space, right? So anyway, I don't know. I think premolars in the maxilla are a little bit different style. I tend to take out the segment of bone with the teeth when it comes to maxillary removal, and then I don't take out the palate, just that segment in the alveolus. So you really haven't taken out maxillary premolars? I feel like this conversation makes me feel like I'm crazy or something.
You are,
Yep.
for starters. And then, yeah, again, I think there's a difference. Taking out teeth, yes. Taking out teeth and closing the space at the same time.
Because
I really don't think I have.
it isn't, I mean, because there are papers, and I've seen at least this published a few times for airway perspective of taking the entire strip out. So you bring the posterior maxilla forward. You heard about that? Like, because
Yep.
you're advancing it. And so I can't think of well, I mean, I think an airway is always a consideration, but the amount of advancement in the posterior maxilla or in the mandible, like the other case, I think airway is a reasonable extra benefit from this. So maybe in a situation where the anterior maxilla, you see my Instagram post,
Yeah.
the anterior maxilla needs to move back a little bit, but then they want some breathing benefit by the posterior maxilla moving forward, taking out some premolars, the strip of bone with the teeth, and then closing the space. Isn't a bad game plan. I think it's a good balance between kind of form and function in some people. So
Hmm.
um, I think that I've done a bad job convincing you to do this. We'll see. Let's see your next like 6 months of planning to see if you, I bet you it comes up now that you've thought about it.
I mean, like I told you before we got on here, I think that's part of it is I don't even, because my experience level with it is so minimal, like it's not even something I'm considering when I plan. And I would liken it to subabicals or mandibular body osteotomies. It's just things that you do so, or I do so infrequently and have such little experience with that I probably miss situations where it could be utilized for an alternative option. Like instead of saying, hey, Mr. Miss Patient, here's the alternative option, and we do this, and maybe it saves you months of ortho, or we could do this. Occasionally I bring out the subapical, but some of this other stuff, I probably just because it's not something that's in my routine treatment planning and execution.
I have the impression, by the way, that this is a technique that time has lost. I feel like this was a utilized technique in the past, both from the idea of Myron teaching that sort of thing. But you plan with dolphin, right? And
Yeah.
dolphin has extraction of premolars as one of the plans. Like they have it to be so common so as to allow that option in the surgical planning. Um, so I don't think it's completely unheard of. So
Do you think that's meant for the actual surgical planning or just like overall treatment planning though? I mean,
I think it's meant for surgical planning,
yeah.
but maybe both. Maybe both.
Hmm.
Software's been around a bit. So I think in some situations where minimizing the time in orthodontics, maybe creative treatment planning, maybe maximizing airway change in a face that doesn't tolerate a ton of advancement, um, symmetry, aesthetics, entertaining the idea of premolar extraction can be good. So there's some people I meet that are missing multiple teeth, by the way, and are going through jaw surgery, and saving them a couple implants is pretty nice. So not
Yeah, I
a
mean from that perspective, it makes a lot of sense of can we close this space reasonably or do we have to do an implant or because sometimes you're doing an implant, you have to either create space and or bone graft to get adequate bone. And so that's not a short road sometimes. And so yeah, I mean you're the fundamental of the I guess the indications that you're giving me make a lot of sense. I don't know, man. I
all
don't know.
right. No, I appreciate the skepticism. Um, a lot of times when I'm planning, I'm thinking to myself, am I overcomplicating it?
And
Um,
that's what comes to mind is not necessarily that it's even overcomplicated. It's just like there's a lot of moving parts and pieces here that maybe would be best to control somewhat orthodontically before or after. I don't know. I don't know. Maybe I just need to try a few, and then when we are still recording this podcast in 5 years, I'll chime in with a different perspective.
yeah.
You
Um,
think we'll get listeners who chime in and say, "Oh yeah, I do that regularly."
I kind of feel like it. I feel like the removal of teeth or the closure of spaces during jaw surgery, surgical closure of spaces. Um, I bet you there's some fans out there with that game plan. So look forward to hearing from people.
I bet if we polled our listeners, what percentage do you think would say that
Oh,
they do that or have even
small
ever done
percent.
it?
Yeah, okay. From that's probably a small percent, but hopefully the vocal minority throw some love towards my game plan of taking premolars out.
Yeah, I
But
mean,
I'm
I
open.
definitely would love to hear other people's perspectives. I mean, I'm sure it's done. I'm thinking back to my days at Children's when we were frequently dealing with, adolescents who had clefts and other congenitally missing teeth problems and issues. And I'm trying to remember. I feel like I probably did do some of this, and I just don't recall it.
It was such an experience that you blocked it out.
I was so traumatized and probably sleep deprived that I don't even remember it. And so high
Yeah.
off of
I think
acrylic.
there's a lot of little things with jaw surgery that's useful to have once you figure out the basics. And I think that's a lot of the stuff we talk about. So I think the premolars just put a little bug in your ear.
All right. You got anything else to throw at us for this? Things
I
to
think that's
consider
it.
or okay.
No.
So the Mariners tonight, you think they're gonna pull out the win?
Oh yeah. Yeah. I feel good about it. I prior to being a Mariners fan was a Cubs fan. And so, I realize there's a lot of disappointment in baseball. Um, but I'm optimistic. We'll see.
Man, your optimism is admirable. I'm not on par with your optimism. I'm just assuming we're gonna lose. Maybe that's a bad attitude to have, but I have a feeling it's gonna get late early out there. You know what I mean?
Yeah. Well, we'll see.
Oh wait, does that count as an old man saying?
I think there are some kind of ones in there. So
I
let's
mean,
see. We
you're
got
familiar with that one, right? It's getting late early out there.
I'll be honest, I have not heard that one.
That's from a very famous baseball player. You could probably guess. He has a lot of those kind of sayings.
It's Yogi Berra, yeah.
Yeah,
It's getting late early out there,
getting
is he
late
saying?
early. Yep, yep.
Huh,
Unless I'm going to say I'm 87% sure.
that's pretty good. It's a high percent.
All
Nice.
right.
All right, man. Well,
Well,
thanks
yeah,
for bearing with
till
me
next
today.
time. Yeah, we'll go on. I'm interested to see if we get a response from this, and hopefully we're talking about the Mariners in the World Series next week, but we'll see. See, man.
All right, man.
All right, see ya.
Catch you later.